obstetric work.
Yeah. No, there are two or three webinars going on simultaneously in obs and gynae itself.
Yes, I did just finish one. Now I'm on second, but in between I managed obstetric cases also. So, well, anyway, some days are like that.
You are one dynamic person, madam.
Thank you so much.
So many things, ma'am, you manage, my God.
Because what is happening even during campaign, I'm continuing with my clinical work. You cannot stop. You can't run away from your practice in want of your,
Very true, very true.
because it's very important. Because patients trust you, no, they just come for you,
Exactly, very
and you
true.
can't say no, or you can't.
You can't always relegate also.
Yeah. So I think it's 7:30, Dr. Rupali.
Yes, I think
28. 28. So
28.
Dr. JB Sharma, Dr. This our chief guest and guest of honor, and Dr. Sushmita, if she has joined.
I'm here.
Dear Sushmita, I gather because of you, my team, Anjum had a little lighter time this time.
Yeah,
She said because
definitely.
you helped her get all the faculties. Sometimes what happens, she keeps calling, people don't pick up, then Anjum will say, ma'am, this person is not calling. What do I do?
I
And
am
this
very
time I didn't
persuasive.
had any phone call from Anjum.
Yes, he put up the whole program
I
actually.
am very persuasive and I emotionally blackmail people to join. I have my methods. Rajiv Da will agree with me.
Yeah. No, if one has the will to join, they will join. They will always find time.
Yes, true. Now, this is a very interesting topic as well today, isn't it?
Yes, very interesting. Very.
Hang on, I'll call Bashov and see if he's joining.
So Basav has to join, no? Basav, JB. Is Dr. Purnima joining?
Bashov is joining in 5 to 7 minutes. 5
And
minutes.
what about Purnima?
Welcome, Purnima Satuskar, madam.
Hi.
Hello, how are you? So nice to see you.
Yeah.
Hi,
it's
Purnima. How are you?
Yeah, Archana, you're all
Yes.
over the place. It's good to see you visible everywhere.
I have to be, no. There are some places, like simultaneously conferences are happening, and I see, I couldn't go there. But then you can't be everywhere, no.
Madam has 48 hours for her in one day. She's blessed. I just called
Abhi,
Baby Sharma sir. He's just joining.
yeah, because I told Rupali because there was a like tug of wars between me and Purnima for Rupali. Purnima said, "Give Rupali to me." I said, "No, just 15 days remaining. Let Rupali be with me." She said, "No, no, no. I have my conference coming up." I said, "Well, Rupali has been there from the beginning, so let Rupali and Anju do this RCOG. We do one on 24th and one on 31st, and then you are free, both of you.
Okay, ma'am.
Not free from the campaign,
Yes.
though, but yes,
They've done a
for,
fantastic job, I think.
I know."
No, what happened, like a lot of people were out of action in my committee. The
Hmm.
NEET had to be done again. So one of them was out, and somebody's father was in ICU. So there's no one to work for the conference. That's why I requested.
So just two more webinars, one on 24th and one on 31st. 31st, we are doing a master class, ultrasound in something like obstetrics or something, just 3 or 4 speakers, and that's how we do. And should we combine it with ISPAT? If you think we can do that, if you want.
Okay, let's see. We'll talk about it.
Yeah, let's go. Let's go live, madam.
So,
I think we're just waiting for Dr. JB Sharma sir to join. He did tell me he's joining. Can I make a quick call before starting?
Yeah,
yeah.
like last webinar we did with GOH and CG joining a little later.
Yes. I think Abhi sir join करेंगे. Maybe now. In 1 minute he will join. Hello, Dr. Manila ma'am. Hello, how are you? Ma'am, you're on mute.
बस सब भी ज्वाइन नहीं हुए ना अभी.
Yeah, hello everyone.
Hello,
Hi.
ma'am.
Hello Purnima ma'am. Dr. Rajiv, hello. Good
Hello,
afternoon.
Hello, hello.
And Dr. Basab has joined. Good evening, Dr. Basab.
Hello, everybody. Hi.
Hi, Basab. I don't know when you get out of your car. Every webinar, you are with your seatbelt on.
I know there's nothing we can do here. So much of jumping around. As you are doing now, we are also doing. It's a part of jumping around on the way to airport, Delhi now. Tomorrow, Jammu, and then a few more places.
Hi, Vasant.
Hi, Rajiv.
Hi.
Hello, Manila. Hello, Indrila. Hello, Anju.
Hello.
Okay. Pragya.
Hello,
Dr. Anuja. Hello, everybody. Hi. Purnima. Hi. Nice to see you. Purnima, I can't see Purnima. There's a power cut at Purnima's place. It's putting a leg.
बंद हो गया. Hi.
Thought there's a power cut there actually.
It's not going.
Pulling a leg there. Yeah, Vishwat is here.
So
Hello everyone.
Basab started your journey
Hello,
from now.
In a way, yes. In a way, yes. Not official because it's
Mm.
confusing for people. So unofficial, yes. Not official.
Hi, good evening.
Good
Good
evening.
evening,
Good
Vishwajit.
evening.
How are you?
I am fine, thank you, Dr. Baser. How are you?
I'm good. Enjoying meeting everybody on a screen, sitting in the home.
Nice to catch up with you again.
Same here. Yes, we met in Chennai, I think, in AICC RCUG. Yes, remember.
Asaf is doing a tour of India today. Today I met him in the
Yeah.
OT and he gave me a schedule, which is
Hmm.
like Jammu now, Kanyakumari tomorrow.
So Kashmir to Kanyakumari in one, no? That's what
Yeah.
KK, K2K. I think good that he has started, in time so that he can visit
Yes.
many places. It's important.
Hi, JB.
Hi, Basab, how are you?
Nice
Hello,
to see
Dr.
you.
Sharma.
Namaskar. How are you?
Hello, JB. How are you?
Hello. Hi, so Viswajit. Good.
How
आपको
are you?
congratulations नहीं हुआ JB का congratulations नहीं हुआ formal congratulations
अच्छा वो thank you very much. अभी
JB
अभी
in
सर.
person
No,
Oh,
I
तो
thank you.
इसीलिए तो जेबी को आज बुलाए हैं कि
JB
हम
इतना
उनको
relaxed है ना JB इतना relaxed
फॉर्मली
JB relaxed
कॉन्ग्रेचुलेट
है
कर
अभी
दें
JB
वीपी
Oh, thank
बनने
you.
का अपने
हाँ.
अपने आरसीओजी
इसका
प्लेटफॉर्म से
इसका मजा ही कुछ और है नहीं बिना
आई नो
इलेक्शन आना पड़ा.
हमको जेलसी हो रही है ना कि आपको बिना इलेक्शन में
पर आप वीपी रह चुके हो. हाँ, आई नो.
आई
वो
नो
ना बहुत एनर्जी बचता है एक्चुअली ना यू कैन यूज दैट एनर्जी फॉर बेटर थिंग्स.
बट ठीक है इसके भी अपना मजा है लाइक
हाँ, आई नो.
you
Yes,
meet
yes, of
people
course.
you interact with people you
Hmm.
come up with new idea. I think the campaign gave me lot of this thing, like you come up with different ideas, what webinars, what topics you you explore, you read and you meet people and lots of things comes in mind. So I'm really enjoying, like
Yeah, it's all on the journey,
That's
Archana.
right.
That's what I say. It's all they enjoy the journey. Destination is unknown. Nobody knows the destination, but
exactly.
enjoy the journey. That's the important part.
Exactly. I think it's the same. I'm a firm believer that like you choose that's what I want to do. So just enjoy it and keep working for it.
Hi, Dr. Rupali. Hello.
Hello, everybody.
Hi.
I think we have full quorum. Can we start
Yes.
now?
Absolutely.
Yes, ma'am.
Yes, Dr. Anjum.
Hi,
Yes.
Yes, ma'am. We'll start with the Diya lighting.
Yeah,
Sudeep, sir.
yeah, we're live now. Yeah.
A very good evening to all our esteemed faculty and all the delegates who are joining us today.
Good evening, everybody.
Good evening, ma'am. It gives me immense pleasure to welcome you all to today's webinar on acute abdominal pregnancy, decoding the diagnostic dilemma. One of the interesting topic today as a part of focus series under Program Director Archana Baser ma'am, ably guided by Purnima Satoskar ma'am. We are very grateful at the outset to IRC RCOG East Zone for collaborating with us on this webinar today. Without wasting much time, I would now like to request Dr. Rupali Dharwadkar. She's a consultant obstetrician gynecologist at Surya Hospital, Mumbai, having a MS MRCOG, to introduce Program Director Archana Baser ma'am. Dr. Rupali.
Hello, am I audible? Because my internet is a little
Yes,
wobbly.
yes, now you are audible.
Yes, yes.
I'm sorry, my internet is a little wobbly today. So a warm welcome to all the esteemed faculties today. We are into our focus series, which is a brainchild of none other than our Dr. Archana Baser ma'am. It's my great privilege and honor to introduce her. She's an eminent obstetrician, academician, and a distinguished leader in OBGY. She's a director of Akash Hospital, and she has to her credit many degrees. She has earned a reputation for excellence in women's healthcare, medical education, and professional leadership. And her journey in Foxy has been marked by outstanding service and commitment. She's been serving as a vice president of Foxy, chairperson of the Foxy Imaging Science Committee, to mention few. She's a passionate teacher and a mentor. She has trained countless obstetricians and gynecologists across the country. She has been instrumental in promoting excellence in ultrasonography, infertility, minimal invasive surgery, and she's also the Guinness World Record holder. This year, Archana Baser ma'am is contesting for the prestigious office of President of Foxy, bringing with her her vision of inclusive leadership, academic excellence, innovation, and dedicated service to every Foxy member and to women's healthcare across India. So friends, please join me in extending a very warm welcome to an inspiring clinician, visionary leader, and one of the most respected voices in our fraternity. Welcome, ma'am.
Namaskar. Good evening. At the outset, let me welcome all the faculties who have joined here on this platform and which uh, is a focus series by AICC RCOG West Zone, for which I'm really thankful to our chairperson, Dr. Purnima Satoskar, for giving us a free hand to do these webinars and to collaborate with other states and other zones of the RCOG. And I'm really glad that this time the East Zone chairperson, Dr. Basab and Dr. Sushmita, who have agreed to join us, and we could have a good faculty members all suggested by Sushmita and connected by Sushmita. And she just now said that I emotionally, tell people to join, because sometimes it has happened that our Anjum was having little difficulty in connecting with the people. And I'm really, really, really happy to say that Dr. Rupali and Dr. Anjum and Dr. Manila Koshal, for some of our focus series, has been the really the backbone of this focus series. And they have, I think this is our, if I'm not mistaken, this is our 13th of the focus series. We started last year, and many of our faculty members have joined in here, and many topics, just one focus topic we take in each of our webinar. And today we have taken a topic of acute abdomen in pregnancy. I think this is one of the very common problem all the obstetricians and gynecologists face, and this makes a big chunk of patients coming to our OPD in pregnancy. So I'm really happy, and I would like to first welcome our chief guest for today's evening, Dr. Basab Mukherjee. We all know Basab Mukherjee, and Basab Mukherjee had been the Vice President of Foxy. Currently, he is chair of East Zone RCOG, and he has had several organizational roles: Yuva Foxy, Endogen, AICOG, Fitovision. We have seen his capabilities to organize different events, and he has been a very great academician. And above all, he's a good friend, and he's always there whenever you ask Basab. We want to invite you. Unless he's busy somewhere, he will never say no to us. And he has been a clinical examiner for MRCOG Part 3. So we'd like Basab to address our gathering here today.
Thank you, dear Archana. Thank you. A warm welcome to everybody who has joined here. This is an academic program, so I'll keep this short, but it's lovely to see RCOG forum or the RCOG platform being used for these webinars, which is a great because RCOG is characteristically associated with very good and strong academia, and so we will like to keep the focus on academia as the plan is. Acute abdomen in pregnancy, as Dr. Archana has said, is something which can stump a lot of people who've seen a lot of pregnancies but don't know exactly what to do and how to deal with it. So I'm sure that over the discussion which ensures with the panelists and the experts which you have brought together, we will have some clarity to the audience who has joined. And I'm sure that this will be recorded and people who would miss out could possibly go back and see it again. So I'm sure that there will be a lot of good academic exchange. For Archana, she has been a dear friend for more than 15 years. We have connected through RCOG initially and then FOGSI later. And then in AICOG, she was the organizing secretary preceding our Kolkata conference, because Indore 2022 and then Kolkata 2023, we were working closely and I've known her for a very long time. My best wishes with her for her future FOGSI presidential election. And let's hope that she comes out with flying colors, and we hope all the very best to her. Thank you, JB. Dr. JB Sharma is again a very long time friend for the last 15 plus years. JB was one of the initial persons who started MRCOG exam in India. That was in 2014, 15, 16, and during the Diwali time, which we remember nearly 10 years ago.
Yes.
It was there in Le Meridian, where a few of us had gone and started MRCOG Part 2 at that time. There was not Part 3. And then later Part 3 came and more people were trained, and then the exam went on. So JB has been really a flag holder of MRCOG exams in India from the very time it was started. So whenever in RCOG they talk about exams in India, JB is always consulted, and JB's values are always highly opinionated. Thank you, JB, for being here.
Thank you.
Lovely
Thank you.
meeting everybody. Dr. Shushmita is absolutely the workforce of RCOG, a silent worker. She is a brilliant person in general. For people who don't know her, you will know she doesn't mince her words. She's very sharp-witted, and she is a lovely person to hang around with. So Shushmita, thank you for all the effort that's gone in here. Also, thank you, Dr. Anjum and Dr. Rupali and Purnima, for tying up with us for this particular one. Thank you all, and look forward to a wonderful academic session. Thank you.
Thank you, sir. Thank you, sir.
Yes, sir.
Thank you. Thank you, Basa, for your kind words. And it's quite encouraging. And we'll keep it to academia. I think RCOG platforms are known for academia. Let me now introduce our guest of honor, Dr. JB Sharma. Again, JB, I have never, his full name is Jai Bhagwan Sharma. If any one of you don't know, we have never called him with full, we just always call JB. And JB is again one of a gem of a person, and he is now the vice president elect for the FOGSI, and then he has lots of awards to his in his kitty, BC Roy Award, and he has work experience, former professor and unit head at AIMS New Delhi. So you can imagine the amount of experience and then the work he has done. And look at the publications, 450 publications, more than that, and including more than 200 chapters in journals and the Lancet. And what I can tell about JB, which you may not know, many of you, his sense of humor is amazing. I recently had one meeting with him in Noida, and I think everybody was just, saying that, yes, JB has to be there for the talk. So he has a very good sense of humor, and he is currently
It was so loud.
sorry.
Saying madam is not audible.
Madam got disconnected, I think. Can we request JB Sharma sir to
Yes,
say
yes.
kind words for the webinar?
Okay. Yeah. So thank you very much, Dr. Archana, and everyone for calling me here, and Dr. Anjum, Dr. Purnima, and of course, above all, our Madam Dr. Archana, who is the brainchild for this. And I'm really delighted, and thanks, Vasa, for the lovely words for me. definitely. And when I did the first time RCOG course and all, and then whenever we lack examiner, I just phone Basab that you have to come, and he never says no. So it always wonderful. Our RCOG fraternity is there, and we are like a family, a sub family in a large family of Foxy, basically RCOG. That's really lovely. And thank you very much for everything. And the topic today is extremely brilliant. I mean, it's acute abdominal pregnancy is a big problem. Whenever patient comes to us, all of us get frightened. Is it acute appendicitis? Could it be? Just last week I had a acute torsion of ovary. So we were thinking, should we operate? Should we not operate? It's just 10 weeks. So luckily pain stopped, and also we are just waiting that let her become 14 to 18 weeks of pregnancy, and then we can. So it's always a Pandora box, and sometimes it turns out to be red degeneration in a fibroid when we shouldn't operate. So it's very important and crucial. So I'm sure today's deliberations will delve into that. And thank you, Basab, for excellent words for me. And thank you, Archana, and best of luck to Archana and all others for their endeavors in Foxy. Thank you very much. Wish all the best today.
Good evening, everybody. I would like to thank our chief guest and our guest of honor for their time, guidance, and inspiring words. Now we'll move ahead with our scientific session. I would like to introduce our chairpersons, Dr. Mandakini Srinivasan ma'am, Dr. Mandakini Srinivasan ma'am is a fertility specialist in Petals, Kolkata, and has immense working experience. Also, she has presented various presentations at national and international platforms. Our next chairperson is Dr. Indira Basu ma'am, who is an MD and MRCOG and has also worked in various hospitals in London, currently working in Kolkata, and is also a Basu scholar in obstetrics and gynecology at RJKL Medical College and Hospital. Our next chairperson is Dr. Malina Jain Kaushal ma'am, who is an MSDNB and FRCOG and director of Coral Hospital and Research Center and Mahi Women's Center in Indore. Has also been a past president of the Indore Obstetrics and Gynecology Society and a joint secretary of AICOG in 2022. Indore also has won multiple awards in her name. I would then like to request Dr. Manika Jain Kaushal ma'am to introduce Dr. Archana Baser ma'am as our first speaker and go ahead with the scientific session. Thank you.
I think Dr. Archana madam is there, or she got connected.
Madam has joined back.
I'm here.
Okay, ma'am. You had got disconnected, that's why.
Yeah, there was some power failure, and then all of a sudden everything went off. But now I'm back here.
Okay. So Dr. Manila ma'am, can we have 2 words from you about Dr. Archana ma'am? Then we can start with the session. I think she's not there. Dr.
Yeah, I think so.
Okay. So ma'am,
I think I can start my talk because I'm already being introduced.
Yes,
Yes,
ma'am.
sure.
Yes.
Sure.
Yes.
Thank you.
So may I be allowed to share my screen? So, am I okay to go?
Yes, ma'am. We can hear you.
Yes.
And
I'm
screen
just
is-
keeping my talk very short because I think my co-speakers, the other speakers, Dr. Rajiv and our doctor is going to join us. So they'll be taking. So my thing is diagnostic in acute abdomen in pregnancy. And let me introduce the subject. An acute abdomen in pregnancy requires urgent evaluation, and the uterus shifts abdominal organs and alters pain presentation, making timely diagnosis critical. And life-threatening obstetric emergencies like ectopic ruptured ectopic, placental abruption, surgical conditions like appendicitis, ruptured appendix, they must be immediately ruled out. And acute abdomen in pregnancy remains one of the most challenging diagnostic and therapeutic dilemma today. The incidence of acute abdomen during pregnancy, if you take, is 1 in 500 to 635 pregnancies, and abdominal pain is one of the most common reason for visits to the emergency room. Although for the majority of patients, symptoms are benign and self-limiting, a subset will be diagnosed with an acute abdomen as a result of serious intra-abdominal pathology necessitating emergency intervention, and a definitive diagnosis relies on specific diagnostic protocols and requires ruling out both physiological and pathological factors. So acute abdomen in pregnancy, your initial approach should be gestational age less than 12 weeks, 12 to 28 weeks, or more than 28 weeks pregnancy, and vitals and FHS to see maternal stability and fetal stability. And then second thing is whether obstetric versus non-obstetric cause. Let's just take the non-obstetric causes first, then I'll focus on the obstetric cause. As we know that there can be appendicitis, there can be gallstones. A sludge in the gallbladder is very common in pregnancy. There can be dermoid cysts, there can be even the gastroenteritis can cause acute abdomen, there can be renal stones, and there can be many more conditions which are the non-obstetric causes for acute abdomen. I've just brought two cases, and which actually today was my acute abdomen day in pregnancy. Since the morning I walked in, I knew that I have to speak on acute abdomen, and I was just thinking, and this patient comes in at 9:30 a.m. in the morning. She's gravida 2, para 1. She had a previous cesarean section, severe acute abdomen pain, 35 weeks, 3 days since morning. On examination, she had a pulse rate of 104 per minute. Blood pressure was fine. SpO2 was 96. Uterus was little toned up. She had a breech presentation. Cervix was undilated. We did send blood for the investigation, and our best investigation which is available, easily accessible, and we are trained to do it, is ultrasound. Did an ultrasound. I mean, I had in mind that probably I'm dealing with a scar, thinned out scar, single live breech placenta grade 3, and the scar was thin. So look at this picture. Just today only we scanned her. The cervix was long and closed. She was not in labor, and her scar was thin. So basically the ultrasound is a modality of choice for acute abdomen in pregnancy. So, and if you look at the other diagnostic modalities, if you see just from the history and clinical examination, 60% of the diagnosis of acute abdomen can be made. In the history, you should ask about the onset, site, radiation, any vomiting, bleeding, leaking, that we all know what all questions to be asked. And in examination, very important is the pulse, is a very important thing, blood pressure, any contractions, and vaginal examination if patient is in labor. And then blood workup and urine examination, because UTI is one of the another problem which sometimes can present with an acute abdomen. Obstetric workup, you will do ultrasonography, Dopplers, ectopic, abruption, placenta previa, fibroid degeneration, ovarian torsion, and what you have to make assure is the fetal viability, and CTG also has to be done in the obstetric work. Now, pain in early pregnancy. This is my another second case. A young patient presented to us with, it is a little unusual case. A young patient presented to us with primary subfertility. Her reports were normal. Her BMI was normal. Age is 25. She had HSG done somewhere. Husband semen analysis was normal. We did a scan and found an adenomyotic cyst. We advised surgery, but patient refused. And to our surprise, she conceived with follicular monitoring. So this is her picture. So this is again a very recent patient. This was her picture when she was not pregnant, this adenomyotic cyst. And let's see what happens. She comes with an acute abdomen. We needed to admit her. And this was her picture with adenomyotic cyst. And this is in pregnancy there. Now you are in dilemma what to do. patient is having severe pain, patient is having adenomyotic cyst, and she is conceived after subfertility treatment. We kept her on some progesterone, reassured her, and we knew that adenomyotic cysts do, settle down with the time, did a counseling, and we followed up the patient, and at 9 weeks, the cyst had resolved, and the patient complaint had resolved, and this is the picture, and this is the adenomyotic cyst, which is resolved. So this kind of cases do happen, and ultrasonography comes to our rescue. Most of the cases we can diagnose by ultrasonography. I am been imaging science chair for the FOXY and SOFOG, and in AOFOG also. I think imaging is something which all obstetrician should learn to do, and imaging, we should be sono obstetrician and sono gynecologist, because modern times practice, initially we were used to do the vaginal examination. Modern gynecologists are, with one hand they have the transvaginal probe, and in another hand they have endoscope to diagnose most of their problems. So ultrasonography is a preferred modality. Number one, it is available. We have trained personnel, and as a gynecologist, we are also training. We have lots of courses and CMEs where we can learn. And another, which is very important thing, is the acceptance by patient that yes, they themselves come that I have a little pain, please do my sonography and see. So it is acceptable to patient, and it is safety is established. Very few cases with the acute abdomen do require the MRI in the pregnancy. I mean, till date, I never needed to do MRI, but I do know that some cases may require MRI, and we know that CT scan is not advisable or a preferred method of diagnosing the acute abdomen. Endoscopy, yes, if needed, we need to do it. And Pragya is, if she joins, Pragya is going to take the laparoscopy for acute abdomen in pregnancy. So this is also one of the modality which we need to use, not only for the diagnosis, but for treating the pain in abdomen during pregnancy. So endoscopy will also be dealt with. So just to summarize my talk, do not delay action for want of investigation. We are clinician. We need to take decision based on our clinical judgment, like what we did in both our cases, though we had ultrasonography. But sometimes what happens, many of our doctors are working in the places where investigation modalities are not available, and then they really have to rely on the clinical judgment, and the clinical judgment, the patient's vitals and the history makes you 60% of the diagnosis. But ultrasonography is something which we should all be armed with in our armamentarium. It should be there to diagnose. There are so many non-obstetric causes of pain in abdomen where you have to take help of your radiologist colleague. And if patient is in acute agony, surgery needs to be done, it needs to be done. You cannot delay because patient is pregnant. It's a 9-month journey. You cannot defer the treatment of a certain clinical condition which is there. So many, the acute abdomen presents in the emergency room, and that's a very, very common occurrence. So thank you very much for patients listening. And I am here requesting you all to vote for me and support for me for my FOXY presidential candidature in 2026. I'm with you, I'm for you, and I'm by your side. And most of all, I'm one of you. So I'm grateful for your trust over the years. With your support, I'm advancing in FOXY together. And please bless me with your support and vote. Thank you so much.
Thank you, Archana Baser, ma'am, for your amazing talk on diagnostics in acute abdomen pregnancy. I would like to request our chairpersons to share their valuable comments on this.
Hello, ma'am. Good evening. Can you hear me?
Yes, ma'am. You're audible.
Yes.
You are audible, doctor.
Good evening, ma'am. Thank you so much for that lovely presentation, ma'am. I have one question regarding acute retention of urine mostly in the first trimester, ma'am. Would that would also come under the causes of acute abdomen pain in pregnancy, right, ma'am?
Yes, yes, it will come. As I said, that urinary tract problem will also come. It does come, and then you have to treat by catheterizing the patient, and you will scan and you will see that her bladder is full, or even by palpation you can find out. It will come in acute abdomen. Yes.
Ma'am, sometimes I have seen in one or two patients, even post conservative management, it repeats again. Even in the second trimester, this happens, ma'am. So, what should be the plan of management for in such cases?
You know what, how I manage, Dr. Srinivas, in such cases, because invariably the acute, the retention of urine in the early pregnancy is because of the retroversion of the uterus. So retroverted uterus causes this. So you have to catheterize. Now the problem is because we remove the catheter early. Just do the catheterization, make the patient urine drain, and the patient feels relieved and patient is sent home. I think this we have to really change our thing. We keep the catheter for maybe 7 days, because retroverted uterus is not going to become antiverted just as as you have drained the bladder. So patient has to be sent home with the once you send the patient home with the catheter, as the uterus rises above like 12 to 14 weeks, then her retention problem will go away. To answer your second question, that sometimes patients do get in the second trimester, it is again maybe because she is getting the urinary tract infection. So you need to treat it, and sometimes you might need to catheterize her.
Right. Thank you, ma'am. Thank you so much.
Thank you, madam, for your excellent presentation.
Kept it short so that my colleagues, like with ovarian, I'm
Yes.
really, looking forward for ovarian torsion and endoscopy in acute abdomen.
Thank you, ma'am. I would further like to request Dr. Mandakini ma'am to introduce Dr. Pragya Mishra ma'am for her further as our second speaker.
Can I start sharing my slide?
Welcome, Pragya. I hope all set at your home now. I was reading that your mom is not well, so thank you for joining.
Can I have the introductory slide, please?
Yeah.
Hello, Dr. Pragya.
Yeah, it's there in my. I'll just share my. Okay, fine. Okay, fine. You give the present.
Can you? Yeah, there we are. Yeah. So yes, thank you, Dr. Pragya, for joining despite all the challenges at home. So that's really very, very kind of you. So it's very impressive slide here that I see. She's an FRCOG and a PhD. May I ask, what is your subject of PhD, Pragya?
It was lipid profile and in pre and peri. Hello.
I think there's some connection disturbances at her end. So yes, she has plenty of awards to her credit, and she's the president of Patna Obstetric and Gynecological Society in the 2025-26 academic year, and she's been the past secretary of the General ISO PARB 2222 to 26, and the council member of ICOG, chairperson genetic and fetal medicine. That's really very impressive, and the founder secretary of Bihar chapter of ISAR. So, Dr. Pragya, with all that wonderful awards to your credit, we look forward to listening to your presentation on laparoscopy. That's your topic, right?
Yeah, yes, Pragya's topic
Yes.
is that laparoscopy in acute abdomen.
Yes, yes, yes.
I'm connected to the Wi-Fi, but it looks like, it's not very good. Can you hear me?
We can hear you, Pragya.
Can you hear me?
Yes, Dr. Pragya, we can hear you. It's a little disturbed, but we can
If
hear
the
you.
Wi-Fi is not good, please
No,
switch your video off and share your slides. Then we'll
Yes.
be able to hear you better. If you share your slides, Pragya, switch your video off, keep your audio on.
Pragya ma'am, are you there?
Yeah, I'm there.
Yes, ma'am. Now we can hear you.
Okay, so I'll just share my presentation.
Yes, ma'am. Please share.
Yes, ma'am.
Yes, ma'am. We can see your slides.
So shall I start?
Yes, ma'am. Please start. We can see your
Okay, actually I'm sitting in my clinic. It looks like, although I've logged in through my hotspot, but suddenly it's taking up the Wi-Fi also, and the Wi-Fi connection is not very good. So if somebody can call me if there is a problem, then I'll immediately switch over to another this thing.
Sure,
This
ma'am.
is perfect. This is
Ma'am,
perfect.
right now it's all perfect.
Okay, fine. So, good evening, all of you. And first of all, thank you to AICC, RCOG, East Zone and West Zone, especially Dr. Archana Baser, Dr. Sushmita, and Dr. Anjum for her efforts, Dr. Basav Mukherjee, who's the AICC IRC East Zone Chair, for giving this opportunity to me. And I thank you, dear chairpersons, for the kind introduction. I know I'm a bit tensed while giving this talk because of some problems which I shared, but thank you so much once again for the opportunity. So we just had a very short, sweet talk by Dr. Archana Baser on acute abdomen in pregnancy. So I'm supposed to speak on laparoscopy in pregnancy for acute abdomen. So the learning objectives of my talk are to understand indications for laparoscopy during pregnancy, review maternal and fetal safety, then discuss technical modifications according to gestational age, then examine current guideline recommendations, and review management of common surgical emergencies. So this is basically an overview. So acute abdomen complicates about 0.2 to 2% of pregnancies and remains a major cause of non-obstetric surgery. And delay in diagnosis is associated with increased maternal morbidity, fetal loss, and preterm labor. And advances in minimally invasive surgery have made laparoscopy the preferred approach in appropriately selected pregnant patients. Now, the common causes of acute abdomen in pregnancy can be obstetric or gynecological or surgical. So under obstetric causes, we have placental abruption, uterine rupture, degenerating fibroid, round ligament pain. So these are some of the common causes of obstetric causes of acute abdomen. And you can see some pictures on the right side. Then common causes of acute abdomen gynecological, we have adnexal torsion, we have ruptured ovarian cyst, we have hemoperitoneum, torsion of pedunculated fibroid. Now on the right side, lower down, you can see there's an anechoic collection of fluid, which is just around, it's probably one of the cysts which has ovarian cyst which has ruptured. And on the top, you can see a case of torted ovarian cyst on the right side. And some of the surgical causes are acute appendicitis, acute polycystitis, small bowel obstruction, perforated viscus, then mesenteric ischemia. Then why diagnosis is difficult? It's because there are physiological changes during pregnancy, which we all are quite well versed with. We know that there is displacement of abdominal organs, then leukocytosis. Normally, if 11 is the upper limit for the white cell count in pregnancy, the upper limit is about 17, which can sometimes give you a confusing picture if there is an acute abdomen as well. Then altered pain localization, then nausea and vomiting, increased heart rate, reduced abdominal guarding. So all these features, these physiological changes during pregnancy can often lead to confuse the picture and lead to a delay in the diagnosis. So when it comes to, when we go to the imaging approach, well, the first line is always an ultrasound. And in this picture on ultrasound, what you can see, there is a breach. It was a case of ruptured uterus. So you can actually see the center, that echogenic area, that hypoechoic area, which you can see, or anechoic area. And that's actually a case of ruptured uterus. Now, second line, we have MRI, and a third line, we have CT, which is reserved when essential, and radiation dose is usually below teratogenic threshold. So it shouldn't really be a cause for worry if you really have to do a CT scan in pregnancy. Now, common surgical emergencies, like if we see like appendicitis, it's the most, if you look at the frequency, it's the most common surgical emergency in pregnancy. And cholecystitis is the second most common cause for acute abdomen. Adnexal torsion is common in the first trimester, and bowel obstruction, it's rare, but it has a high mortality. I've heard of some of my colleagues, who have come across rare cases of bowel obstruction, but yes, a few cases, but very few cases I've heard from them. Some cases I've heard, following a cesarean section, they've ended up having a bowel obstruction. Now, why laparoscopy? The advantages include less post, then lower wound infection, then reduced thromboembolism, shorter hospital stay, faster recovery, and better visualization. Now, is laparoscopy safe? Well, current evidence demonstrates no increase in congenital anomalies. It doesn't lead to an increase in congenital anomaly doing a laparoscopy. Sounds quite absurd also. No increase in the risk of miscarriage. The fetal outcomes are comparable. Then there is lower wound complication rate and reduced post-operative IES as well. So if you do a laparoscopy instead of a laparotomy in pregnancy. Now, what about the timing of surgery? The previous belief was that in pregnancy, the ideal time is, or you can only do surgery in the second trimester only. But now the current evidence says that any trimester is acceptable if surgery is indicated, and delaying surgery increases maternal and fetal complications. So the guideline recommendations by the major societies including the Society of American Gastrointestinal and Endoscopic Surgeons, ACOG, Royal College of Obstetricians and Gynecologists, they all recommend do not delay indicated surgery. Laparoscopy is safe in all trimesters, and maternal stabilization is, of course, the priority. Now, the technical considerations, patient position in the first trimester, a laparoscopy can be done even when the patient is supine or flat, but after 20 weeks, ensure that, there is a left lateral tilt of about 15 to 30 degrees in order to avoid aortocaval compression. It does make laparoscopic surgery a bit difficult because you have to put a wedge and slightly tilt the patient to the left, but we don't have any choice. Now, entry techniques, the preferred methods are open, like going for Hassan's technique, optical trocar, then Palmer's point in selected cases. Well, Palmer's point, as you know, it's in the mid-clavicular line, about 5 centimeters below the left subcostal margin. Then avoid blind Verries insertion in advanced pregnancy, because sometimes, you know, we can cause trauma to the uterine fundus. Now, port placement, first trimester, like you can see a beautiful diagram on the right side, you know, showing that the pregnancy is 12 weeks, 16, 22, 28 weeks. So in the first trimester, umbilical entry is acceptable. You can go through the umbilicus. Then second trimester, you have to go supraumbilical, as you can see in the picture. And in the third trimester, one has to go through the xiphoid or left upper quadrant. That is just below the xiphisternum. Then ports are placed according to uterine fundal height. I mean, that you just have to remember. So a practical, guide or suggestion would be just check the height of the fundus and go above it. So that's something to be remembered. So pneumoperitoneum. So what is recommended? That the initial pressure should be about 20 to 25 millimeters of mercury. That is just briefly for the entry of the Verries. After that, the operating pressure should be brought down to about 10 to 12 millimeters of mercury, and maximum generally less than 15 millimeters of mercury. Now, maintain maternal normocapnia. Too much CO2 insufflation during laparoscopy in pregnancy can lead to severe maternal and fetal complications. Now, carbon dioxide, what are the concerns? Like potential issues are maternal hypercapnia, fetal acidosis, and so too much CO2 can cause maternal respiratory acidosis, fetal hypoxemia, reduced uterine blood flow, and dangerous gas embolisms. Now, prevention, we have to always monitor end-tidal CO2 monitoring, which is, of course, the anesthetist's job, and adequate, we have to ensure adequate ventilation and avoid prolonged operating time. Now, intraoperative monitoring, we have to really monitor the mother and the fetus both. So for the mother, we have to put her on to the ECG and put on the pulse oximetry. We have to continuously monitor her blood pressure and end-tidal CO2. For the fetus, we have to do a Doppler before and after surgery, and especially continuous fetal monitoring when the fetus is viable and technically feasible. Because obviously you cannot monitor when the fetus is not viable, and sometimes it may not be technically feasible also to monitor. So in those cases, you will have to do sort of intermittent monitoring or pre or post surgery. Then anesthetic considerations, rapid sequence induction, aspiration prophylaxis, maintain oxygenation, avoid maternal hypotension, then left uterine displacement, which is very important, and thromboprophylaxis for the patient. Now, condition-specific management, like for acute appendicitis, well, it's quite one of the most common indications for laparoscopy for acute abdomen in pregnancy. Early laparoscopic surgery is quite feasible, and reduces perforation, and laparoscopic appendicectomy is preferred. Now, for acute cholecystitis, the indications for some surgery, suppose if there is, because normally, in a pregnant patient who comes with the gallstones, we do like to put her on conservative management, but sometimes it may not be possible to avoid the whole length of the pregnancy. So, and that too, if she has persistent pain, recurrent attacks, and if it's related to the pancreas, then we have to go ahead and do a laparoscopic cholecystectomy, which is quite a relatively common cause for acute abdomen in pregnancy. So laparoscopic cholecystectomy is safe throughout pregnancy. Adnexal torsion, now common before 16 weeks, as I mentioned. So ovary should be detossed whenever possible. But however, we really need to try our level best to preserve ovarian function, and cystectomy, carry out cystectomy if indicated, and try to preserve healthy ovarian tissue as far as possible. Because, you know, I have seen prescriptions of patients who have been treated by surgeons and who have actually come, well, the patient has been lucky that, you know, one ovary has been preserved, but, you know, they have just removed the other ovary. Whereas, you know, for a small cyst, they could have actually tried to preserve healthy ovarian tissue. So on the right, you can see a case of, this is a case of a torted ovarian cyst, and there's collection also some inside. You can see in the ultrasound picture. And a ruptured ovarian cyst, I think I showed this picture in one of my previous slides, I'm not sure. So, but well, she has to be well, hemodynamically stable also. And if there is persistent bleeding which is not being controlled, or if you are not certain of the diagnosis, well, in these conditions, one can carry out laparoscopy during pregnancy, and it is usually feasible in pregnancy, carrying out laparoscopy, because, you know, we all do laparoscopy for ectopic pregnancy, for self-injectomy, and for heterotopic pregnancies. Now, bowel obstruction, it requires early diagnosis, prompt surgery, delayed intervention, markedly increases fetal loss. That because the more you delay, I think it's not only about fetal loss, but maternal morbidity also increases. So that's again bowel obstruction, which can be handled by surgeons through laparoscopy during pregnancy. Now, maternal outcomes compared with laparotomy, the advantages are less pain, lower blood loss, fewer wound infections, then earlier oral intake, shorter hospitalization, and faster recovery. Fetal outcomes, the current evidence shows there is a similar fetal survival with laparoscopy compared to laparotomy, then similar miscarriage rates. So basically, laparoscopy doesn't put a pregnant patient at a higher risk compared to laparotomy. Then similar congenital anomaly rates, meaning that it basically has no relation with a congenital anomaly. It's the same, like it's just incidental or coincidental. Now, lower maternal complications, indirectly, they benefit fetal outcome. So that's another advantage of laparoscopy. When convert to laparotomy, well, conversion to laparotomy is, well, one should not be embarrassed, or it's not really a complication. And indications include poor visualization, if there is uncontrolled bleeding, extensive adhesions, suspected bowel injury, maternal instability, where in these cases we have to convert laparoscopy to a laparotomy for acute abdomen in pregnancy. And practical tips: operate early. Experienced, it has to be done by an experienced laparoscopic surgeon. Multidisciplinary team involvement is very important. Then individualized trocar placement depending on the gestational age. Maintain low insufflation pressure. Avoid maternal hypoxia and hypotension, and monitor the fetus appropriately. Some take-home messages: pregnancy is not a contraindication to laparoscopy. Delay in surgery is more harmful than surgery itself. Laparoscopy is safe in all trimesters when indicated. Low pressure pneumoperitoneum and modified port placement are essential. Maternal stabilization remains the best fetal protection, and multidisciplinary management optimizes outcomes. So key recent references were from a Society of American Gastrointestinal and Endoscopic Surgeons, guidelines for laparoscopy during pregnancy, then ACOG and RCOG. From RCOG, there's a scientific impact paper, and recent systematic reviews from 2022 to 25, which continue to support the safety of laparoscopy over laparotomy for appropriately selected pregnant patients. Well, it was, so that brings me to the end of my presentation, And thank you very much for a patient listening. This was quite a brief and a simple presentation. Probably if we had more time, I could have shown some more cases, my own cases of laparoscopy during pregnancy. Thank you so much, and Dr. Anjum, for ensuring that I logged in time for your phone call. Thank you very much. And I know that I have
Nice
interacted with
presentation.
you in the past for ISOPAB also.
Nice presentation, Pragya. It was excellent.
Yes, I agree. It was an excellent presentation. It was almost power packed, I must say. It has had a lot of information, and it's amazing that you could manage to put this up in a very short time despite the difficult situation at home. And I just have one question. You mentioned the need for a CT scan in the outside, sometimes, if at all, if it's necessary. What would be a case where you would want to do a CT scan over and above USG or MRI?
If sometimes you know, the diagnosis may not be very clear, and you may have to resort to a CT scan. Like for instance, you know, today itself, I would tell you that there was a patient who's just about 9 weeks pregnant, and she's coming with spotting and some little bit of pain, not. And now ultrasound is saying that it could be a case of a cervical or a scar ectopic. And MRI is also saying, MRI is saying that it's probably a case of gestational trophoblastic neoplasia. So, I mean, the diagnosis is not very clear. I think in such cases, perhaps, you know, CT can add to add to the information.
Right. Okay. Thank you.
Thank you,
Dr.
madam. Thank you, madam, for the excellent presentation. We will go to the next speaker without wasting time.
Yeah.
Thank you, madam.
Thank you so much, Dr. Actually, Madanki, right?
Yes,
Actually,
that's
first
right.
I thought some people keep calling you Mandakini. So, but I noticed it's Madanki.
That's
It is
correct.
Madanki,
Yes.
Madanki.
Yes. It's a very unusual tongue twister.
Wish Dr. Archana Basir the best of luck for
Thank
her
you.
endeavor. I
Thank
know
you.
you're trying very hard, and Dr. Sushmita for this opportunity, because I
Thank you,
think this
Pragya.
was my
Thank you.
first opportunity as at the RCOG banner. I mean, on Zoom. Thank you.
Thank you, Pragya ma'am, for this outstanding presentation. Can we have Indrila ma'am?
I'll stop screen sharing.
Yes, ma'am. Can we have Indrila ma'am to introduce our last speaker, Dr. Rajiv Dhal sir, for our next?
Yes. Can I have the CV slide of Dr. Dhal? Thank you. It's my privilege to introduce Dr. Rajiv Dhal, who will be speaking on ovarian cyst accidents in pregnancy. And it is a long slide. He is a member National Academy of Medical Sciences, fellow of IMA, Indian Medical Association, honorary professorship of IMA, and several scientific publications and several scientific presentations. Served as faculty in many national and international colleges, and he is a consultant in Peerless Hospitex Hospital and Research Center Limited. Dr. Dhal, the floor is yours. So you can start your presentation.
Okay. Yeah, at the outset, I must thank AICC, RCOG, West Zone, and East Zone for giving me this opportunity. Now, are my slides visible?
It's not
Slide is
shared.
not visible, Rajivda. You have to share. Please share.
Yeah, I've shared it.
Yeah, now it is, I think.
Yeah. Thank you, AICC, RCOG, West Zone, and East Zone for this wonderful opportunity. And thank you, Madam Chairpersons, for introducing me so well. now my topic is ovarian cyst accidents in pregnancy. Much of what I'm going to say has already been covered by Dr. Archana and Dr. Pragya, but there are some specifics which I want to highlight. So, without further ado, we'll go to the next slide. Yeah. So, what about the
Rajivda,
incidence?
can you please make it full screen and can you please make it? Yeah. Thank you.
Okay, so incidence of ovarian cysts in pregnancy. Now, when we talk of incidence, the first thing we should remember is that it's an often an incidental finding, and the incidence is about 1 to 5%. That's what it is quoted in the literature, but it's usually an incidental finding, which has been there for some time, and only because the lady went for a pregnancy ultrasound, it was discovered. So most of them have an uneventful course because most of them do not cause any problem and they can remain silent throughout pregnancy. But there are certain cases in which you have ovarian cyst accidents, and that causes acute complications in pregnancy, which should be dealt with urgently, either by surgical intervention or sometimes by medical intervention. So, what are the cysts that we encounter during pregnancy? Corpus luteum cysts, functional cysts, well, these usually do not cause any problems. And though they don't even grow to a significant size to cause any problems, but it's usually the dermoid cysts, one variety of ovarian cyst, which can grow up to a size when it's easy for it to twist. And the twisting usually occurs sometimes during mid second trimester or early second trimester or even late first trimester, because that's when the cyst gets the space to turn around its pedicle. And another period when it gets an opportunity to twist is the immediate postpartum period, when when the baby has come out and the uterus has again gone back to a certain significantly small size, and then there is more space for the twist to turn around. Now, other types of cysts that we encounter are cystadenomas, serous or mucinous, and then we have endometriomas. Endometriomas can be encountered in pregnancy, although it's difficult for a person who has endometriomas to fall pregnant. But we do encounter a lot of cases who have had endometriomas treated, and then they have conceived and they've come with pregnancy with an endometrioma. And then finally, malignant ovarian tumors. Now, this is the crux of the problem. When you have a torted cyst or a ruptured cyst, you can do, surgical intervention and, you can solve the problem. But if you have a suspicion of malignancy, that's where the problem arises, because sometimes, all the features of malignancy may not appear right away. And so what you have been thinking as a benign tumor all along may actually turn out to be malignant as time runs out. So next slide. This is a literature study by Lazarowitz in the year. Hello. Yeah, 2006. They have highlighted that the specter of possible malignancy can sway the decision for intervention versus expected management. Even the slightest possibility of malignancy will make it difficult for you to come to a conclusion as to how to deal with that patient. So, what are the various types of accidents that we encounter? The commonest one and the most dangerous one, of course, is the torsion. As I've already said, it's the dermoid cyst which can undergo torsion. And there are certain periods of time when it is more liable to undergo torsion. And what happens in torsion is, the ovarian cyst can turn around its own pedicle 2 times, 3 times, and even more. And what is the danger that it poses? It poses a danger of necrosis of the ovarian tissue. So if it is not sorted out in time, you may not be able to salvage the ovary, which is bad news for the patient. And another one is rupture. Rupture may be intracystic rupture. There may be bleeding inside the cyst, or the bleeding may come out of the cyst, and there may be a hemoperitoneum. So rupture and torsion are two important complications which have to be dealt with in an emergency, urgent way. Now, hemorrhage, as I've said, intracystic or outside the cyst. Infection. A cyst can get infected, although this is not that common. And there are primarily two routes how it can get infected, either through hematogenous spread or from the transmission of infection from the lower genital tract. And occurrence of malignant findings. If you find malignant changes in an ovary, that's that's not technically an accident, but that's bad news for the patient, and you have to do specific treatment for that. And an ovarian cyst, if left untreated and grows to a considerable size, it can be a cause of obstructed labor. This is not an accident of the cyst itself, but it's an accident which is encountered during pregnancy, during labor. And, a considerably sized ovarian cyst can cause obstructed labor. So torsion, as I've said, mechanism and effects, size of a cyst. It's usually about 8 to 10 centimeter size. That's that's a typical size when it gets started. Type of cyst, timing of occurrence, symptoms and signs. Symptoms, of course, is acute pain. Acute pain. The patient comes in with acute pain, unilateral usually, and signs, because there may be signs of peritonism also. If there is necrosis of the ovary, there can be peritonism and there is rebound tenderness. So in all, it's an acute abdomen. And investigations and diagnosis, as has already been pointed out by Dr. Archana, ultrasonography, color Doppler. Color Doppler is important because it indicates how much blood flow is going through the pedicle into the ovary. And there is a certain sign called a whirlpool sign, which means how there is a vortex of blood flowing around the pedicle, through the pedicle into the ovary, and if it is suddenly cut off, then that's a bad sign. That's a red flag that you should consider. And of course, if you cannot make a conclusive diagnosis, then you can resort to an MRI. But usually, MRI is not required. It's usually a color Doppler, which usually sorts out the problem. Then how do you manage such a case? What you need is detorsion. So an ovarian cyst, either you can, you have to do a surgical intervention, either by laparoscopy or laparotomy. Laparoscopy is preferred. And what do? You actually detort the cyst. So with the laparoscopic probe, with the laparoscope, you can cause a detortion so that the pedicle comes into the right position and the blood flow to the ovary is restored. And then you do an ovarian cystectomy. But if there is already necrosis and you think leaving behind a part of the ovary would be detrimental for the patient, then of course you have to resort to an oophorectomy. Now, another accident that we encounter sometimes is rupture of the ovarian cyst. Causes, it may just merely be the growth of the cyst. It may grow to a size when it becomes thin-walled and it ruptures. Or it may be due to trauma also. And what are the symptoms and signs? Largely the same as that of a torsion. Acute pain, tenderness, and signs of an acute abdomen, which we are all familiar with. And what investigations we do? Of course, an ultrasound is very important because that indicates bleeding inside the cyst, bleeding outside the cyst, hemoperitoneum. Everything can be visible on an ultrasound. And management usually, what you need is, you drain out the excessive blood that is there. But if the blood is not too excessive, you can, do conservative treatment for some time. You may wait for some time, but usually you have to do a surgical intervention to drain out the blood that has been accumulated and repair the site from where the bleeding is coming. So it's intracystic hemorrhage. Same thing. Either it's inside the cyst or it may be outside the cyst. And symptoms, signs, investigations are largely the same as I've already mentioned. And management is the same. You drain the fluid and repair the site from where the blood is coming. Infection of a cyst is another complication or accident, as you call it, which may happen. Mechanism, either, microorganisms going up the lower genital tract, or it may be a hematogenic spread. Symptoms and signs. In this case, there may be some symptoms of a febrile illness, there may be fever, or there may be a history, characteristic history that the patient has been having febrile symptoms. And of course, there will be pain and tenderness. And investigations, apart from imaging in the form of ultrasound or MRI, you do need a lot of blood workup also. You need to do check, inflammatory markers in the blood, and you might need to arrange for cultures also. And management, maybe, to start with, maybe conservative in the form of antibiotics. But ultimately, if there is no solution in sight, then you might have to resort to a surgical drainage, which may be possible through a laparoscopy. Now, this is another paper, Management of Ovarian Cysts and Cancer in Pregnancy. This is from the year 2015. And what they have mentioned is that ovarian cysts or masses during pregnancy should be accurately evaluated to identify the patients who need surgical interventions from those where a wait and see strategy can be followed. So this is the key word, whether you are going to do a wait and see, or you're going to do intervention right away up front. And that will be, evident only if you can make out whether it's a malignancy or not. That's very important. So rule out malignancy first of all. So after having enumerated the causes and the symptoms and signs of these various ovarian cysts and accidents, the general principles that we have to resort to is history investigation. History is very important. Much of the diagnosis comes from the history only. And investigations also, imaging and blood work and urine cultures, and diagnosis and differential diagnosis. As has already been mentioned by the previous speakers, appendicitis and colitis, they may come into the differential diagnosis. The role of tumor markers. Now, this is very dubious. Tumor markers are very unreliable in pregnancy because they cannot be interpreted as they are interpreted in the non-pregnant state because of varying fluctuant values. So tumor markers are not that helpful in pregnancy. So conservative management is one line of management which can be done in certain cases, as I've already enumerated, and surgical indications, because when you find the torsion with the ovary, time running out for the ovary, you might lose the ovary. So immediate surgery, timing, approach, laparoscopy, laparotomy. Laparoscopy is the preferred, mode of entry into the abdomen. And as has already been said by earlier speakers, it's better to do an open Hassan technique or an optical trocar, and a lateral tilt of the patient. The 30-degree tilt is very important in pregnancies where the period of gestation is more than 20 weeks, to avoid aortocable compression. And special precautions during laparoscopy has already been said, because there is a risk of hypercapnia. So you have to be careful about that. And the complications of these various accidents that they happen, there may be long-term sequelae also. Like if if you don't act on time, and if the infection progresses, it will tell on the entire pregnancy, and it might carry on throughout pregnancy and may harm both the mother and the baby. So serial investigations are sometimes important. So if you plan to do a conservative treatment, say in a case of infected ovarian cyst, then you have to serially monitor the patient, blood work as well as imaging. Now, this study from the year 2013, what they came out with, after a simple monitoring is possible if the cyst is benign, less than 6 centimeters, and does not change. Surgery is required as an emergency or in case of suspicious signs of complications or malignancy. So either an acute complication or a suspicion of malignancy. This is very important. So what are the morphological features of these cysts on ultrasonography? As I've already said, in dermoid cysts, you might, because of the presence of material like, sebaceous material or hair. There may be characteristic features on the ultrasound. Hemorrhage can show as gray areas. Cystadenomas, there may be malignant features or benign features. Like, the number of loculi, the number of papillary projections, solid areas, size of the solid areas, and, presence of ascites around the cyst. So malignant features and benign features are there, as has been enumerated in the International Ovarian Tumor Analysis. And so you can have an idea what you're actually dealing with. So you have to proceed in the right way. A study by Timmerman et al. In the year 2010 showed the rules of ultrasound features, including shape, size, solidity, and results of color Doppler. That's also very important. The blood flow through the cyst on color Doppler to predict a malignant tumor and to predict a benign tumor. If one or more M features are there, or if there is an absence of a B feature, the mass is classified as malignant. And similarly for the benign features. So in conclusion, the takeaways from this presentation are ovarian cyst accidents are uncommon, but they can be potentially serious. So they have to be given the importance that they deserve. Prevention is more important. Prevention in the sense that, the patient must be educated. Sometimes elective surgery can also be done. If you have an ovarian cyst, a cyst which is likely to undergo torsion, the patient may be counseled that elective surgery may also be done early in the second trimester or late in the first trimester. So that will prevent complications. But actually, you can even serially monitor the patient and chalk out your own management plans. But you have to keep that in mind. That should always be at the back of your mind, that there is a possibility of elective surgery also. And time, of course, timely management will salvage the ovary. If you are not acting on time, you may lose the ovary. I think that's the presentation, and I would welcome any questions if there are.
Thank you, Rajivita, for the excellent presentation. I just have one question. If there is a cyst more than 6 centimeters, suppose 8 centimeters, but asymptomatic, we still will go on with the conservative treatment during pregnancy, isn't it?
Yeah, as I've already said, you can go for an elective surgery also. You have to counsel the patient that this cyst of 8 to 10 centimeter or 6 to 8 centimeter size may undergo torsion around 20 weeks of pregnancy. And, elective surgery may be done, say, around 18 weeks or somewhere around that time. It's ultimately the patient's choice, but they must be given the choice of treatment. They have to give their own opinions also, but I think we should offer it to them. Otherwise, if an accident happens, then of course you have to rush in as an emergency.
It will be an emergency, yes. Thank you. Thank you so much.
Okay.
Thank you very much, Rajiv sir, for this for your valuable insight over this topic. Ending the speaking session, we would like to further go ahead with our panel discussion. I would like to introduce our moderators, Dr. Sushmita Chattopadhyay. Can I get the introductory slide, please? Dr. Sushmita Chattopadhyay, ma'am, is an MD, DNB, and FRCOG, and a visiting consultant in Kolkata with a special interest in high-risk pregnancy and benign gynecology. Is also a clinical secretary at BOGS and fellow representative and honorable secretary of the East Zone RCOG. Our next moderator is Dr. Biswajyoti Guha sir, who is an MD and FRCOG again, and is a senior consultant and president of the ISOPAR Kolkata chapter and vice president of the BOGS, and co-chairs the imaging committee of CEFOG. And our further panelists, Dr. Anuja Joshi ma'am, who is an MRCOG with more than 15 years of experience, has won multiple awards, and is also a mentor for the RCOG MTI scheme. Our next panelist is Dr. Bidisha Roy Chaudhary ma'am, who is again an MRCOG, also a Part 3 MRCOG examiner, executive committee member of BOGS and of Kolkata Menopause Society, and also has multiple publications in national and international journals. Next is Dr. Gauri Inkote ma'am, who is an FRCOG consultant in the NHS UK and subcommittee member of BSGE Digital Governance. Dr. Jayanti Kamath ma'am, who is an MD and FICOG, is with special interest in infertility, is secretary at AFG and has various publications and awards as well. Next is Dr. Partha Bhattacharya sir, who is again an MRCOG with special interest in endometriosis and high-risk obstetrics and obstetrics, and assistant secretary of the Endometriosis Society of India. Then Dr. Paushali Sanyal ma'am, who has more than 55 papers in her name in multiple international and national journals, and is a managing committee member of the BOGS and clinical secretary of ISOPAR. Next is Dr. Sandeep Biswas sir, FRCOG with special interest in high-risk OBS and urogynecology, and is a fellow representative of RCOG East Zone. Dr. Sushmita Mitra Banerjee, an FRCOG with special interest in subfertility and endometriosis, and is a senior consultant at Manipal Hospital in Kolkata. Then Dr. Vidya Sheregar Bandukwala ma'am, who is an DNB and MRCOG and is a founder member of the FEPPA, a core member of the GIBS and managing committee of AFG.
Thank you very much for your kind introduction. I'm really honored. Myself and Sushmita both are really honored for presenting today, and I'm really grateful to Dr. Archana Baset to actually organize this in collaboration with the West Zone and the East Zone. And it's fantastic to have such a august gathering here. And I was mesmerized by the talk of Dr. Pragya Mishra, Dr. Rajiv, and of course the talk before that. It was a fantastic talk, Dr. Archana's talk. It was a fantastic one. Especially I enjoyed, I must say, please don't take me otherwise, but I must say that the talk that Dr. Pragya presented in spite of her various problems in her at home now, it was a fantastic talk. Thank you, Dr. Pragya, and thank you, Dr. Archana. Thank you, Dr. Rajiv, for such an excellent talk. I think most of the topics are covered. What myself and Sushmita are going to do is just going to place some cases for you to decipher and let us know the answers. It will be all very simple. So there is nothing very complicated about it. It's all simple that we do every day in our practice. And I'm really honored that we have an international guest today. So thank you everybody for coming in. So let's see how it goes. So I'm going to share my screen. Sushmita, am I okay with sharing my screen?
Yeah, please do.
Let me see if I can share my screen. If it doesn't, then Sushmita will have to do it. I'm unable to share the screen. So, Sushmita, can you do it, please, for me?
Yes. Okay. Am I visible and audible?
Yeah, you are good.
Okay. Thank you very much. Well, let's move on with the panel. Most impressive was of the three talks, I must add here, was the precise and time-bound small nuggets of information in all the talks. And we took in a lot, actually, in that amount of time. We'll be brief with our panel as well. So panelists have already been introduced. Welcome to all. So we move on to the first case. So it's Mrs. XX, who's now about 16 weeks pregnant, and she presents with a severe right iliac fossa pain and mild fever with occasional vomiting. So can let's move, Bishuda, let's go A to Z. Otherwise, it's difficult to, engage all of the panelists.
Of course.
Let's move to Anuja.
Anuja, yes.
Anuja.
Dr. Anuja.
Yes. Hello, ma'am.
Hi, Anuja.
Hi, Dr. Anuja.
What would you do?
What would you do for this case?
So, looking at the scenario, we have to consider few differentials. Looking at the labs, CRP is high, white cells are still within physiological limit of pregnancy, but that is always a dubious finding, and neutrophils are quite marginally high. So, we are probably going to put infection of some kind as a leading cause, and with right iliac fossa pain, appendicitis should be the diagnosis unless proven otherwise. So I will first investigate the patient, and at this stage, yes, it says ultrasound is inconclusive. So when ultrasound is inconclusive, and if we are not, ideally clinical suspicion takes precedence in this case. So we don't have to wait for investigation to go ahead with the surgery. So depending on her pain, we'll first assess that. We'll see her vitals, and depending on that, we will do the investigation simultaneously while preparing, involving multidisciplinary team, anesthetists, neonatologists, surgeon should be called early in this case. And while doing that, we will maybe arrange an investigation, which will be...
So would you involve a neonatologist?
Yeah, exactly my question.
It's 16 weeks. No, not at this stage. Sorry.
Yes.
16 weeks, it's too
Yeah,
early. Yes.
yeah.
We'll involve the other team members. And while we are waiting for all that to happen, if we can get non-contrast MRI done, meanwhile, we will do that. But we don't have to delay the surgery for that. Is my
right. My question here, one of my question here, because we discussed this with Pragya's talk. Anuja, can you elaborate? Suppose this is in a hospital where you don't have MRI. And the ultrasound you have done, it's inconclusive. There is right iliac fossa pain. You are clinically suspicious of an appendix. Who would you call? You will call your surgical colleague, right?
Yes.
Is there any scope of any other imaging in this situation? How long are you going to observe?
We shouldn't delay the surgery for investigation, because if the clinical suspicion is high, then because at this particular stage, appendix, if it ruptures, then there is a very high maternal as well as fetal morbidity, even fetal mortality attached. So I wouldn't delay the surgery for investigation. But if we can, if MRI is not available, and if we have low dose CT easily available while we are waiting for arranging surgery, we will get that done.
Yes. I think this is the message that should go across, is that CT is not a no in certain situations. And the commonest situation where you might have to do a CT is if you don't have an MRI. And a lot of situations, the MRI is not available in small hospitals. And would you be guided by your surgery general surgeon friend, or you? Or would you take decision yourself?
No, we will involve general surgeon early in this case. Definitely.
Sorry, Vishuddha, you were saying something.
Yeah, the only thing, Susmita, is that the CT should be a normal CT. It should not be
without contrast.
Yeah, without contrast. Now, let's move on to Bidisha. Any other, how long would you observe this lady? She's coming with lots of pain.
Yeah, basically it depends on the amount of pain. So if she's not tossing and turning on the bed, then we can give antibiotics and do all the investigations as required, rule out UTI also, and then we can see for say 24
you
hours.
Suspect UTI in a patient who is complaining of right iliac fossa pain, vomiting?
No, just ruling out other causes, sir. In this scenario, it is pointing very much towards
your differentials, one of your differentials.
Yeah. And just for that, we can give some antibiotics and wait for 24 hours and see how she's responding. And in the meantime, we can wait for the reports. If the pain is like I said, if she's not in acute, very much acute pain.
Okay. So you'd like to wait for 24 hours. Now, so what about when would you call a surgeon? Now this is a classical case where you probably would need to call a surgeon. Now we are all gynecologists. We know that
Yes,
this is something
surgeon will be called in the first review only, sir, because the surgical opinion is very much required here, whether we need to go for the surgery at that point of time only, or we can wait. That call also has to be taken by the surgeon if it's pointing towards this acute appendicitis. So basically, as I said, it depends on the amount of the pain of the patient and also opinion of the surgeon, also what they are saying, and we will involve them at the first.
And the clinical features, whether they
clinical features,
treated, whether there is any rebound tenderness or not, whether the patient is becoming toxic or not. So these are the things that you actually would be looking.
Yeah, so the lab reports and all that they have sent, and some reports are already there written, and we can wait for any other as a city report or whatever has been ordered. We can wait for that if required.
Okay, we move on to case 2. I think Gauri, are you there?
Before that, may I just put in one word, Sushmita?
Sure.
Actually, acute appendicitis in pregnancy, gold standard is surgery. You have to involve it's always like involve the surgeon, and because antibiotics often they do as early as possible.
Yes.
So involve the surgeon, go for a surgery, if possible, go for a keyhole. It all depends on the call of the surgeon as well as the gynae team. We monitor like an MDT, and it can be a laparotomy or a laparoscopy as as is comfortable with the team. Because what happens is antibiotics, they fend off this sort of they wall off the infections. Sometimes they make matters worse. So we just give antibiotics as a an interim, but we need to go for a surgery.
Usually, I'll just differ here. Antibiotics would do some good. Yeah, it can what it can actually do is it can help you to delay the surgery for 4 or 5 and 6 hours so that you can get some essential investigation done.
Yes.
So that time you can give you a high spectrum broad spectrum antibiotic that might help. But of course, surgery is the only answer. Now, what would you do? What kind of surgery would the surgeon do? And what would be your your input in that?
So generally, what the surgeons do in case with like 16 weeks, they go for a laparoscopy. Like we and the surgeons, laparoscopy,
right? Now you are worried about your fetus, isn't it? As a gynecologist, I'm worried about my pregnancy, and I'm worried about the fetus. Would you take special care for that fetus?
Basically, what we do is monitoring of the fetus. We do an ultrasound for FPT. This is 16 weeks before going for the surgery. We do an ultrasound. Sometimes, if tocolytics or they're giving a tocolytic drip later, it's not always recommended. But if she does have contractions, you might.
At 16 weeks, would that be advisable? Would you think about progestogen instead of
progestogen? Yeah, progestogen is better. Like a vaginal progestogen we can give, micronized, to prevent miscarriage or fetal loss.
That is
and post-operative.
Actually, these are all not very evidence-based.
Exactly.
These are things we do.
Exactly.
I think probably instead of giving tocolytis at 16 weeks, probably vaginal progestogen gel probably would be better here. I think Gauri has raised her hand. Gauri wants to say something.
No, I think Dr. Sushmita, you covered it correctly. There is not much evidence for tocolysis or even progesterone, but most of the times it's progesterone that they give mainly for supportive sort of logic.
Right.
And we normally do a scan after surgery just for viability, and it's mainly for reassurance of the patient as well.
Correct.
But once viability is confirmed prior to surgery and once a patient has been deemed fit for surgery, then she's sort of explained and informed consent is taken, and it's
This
basic.
is much more common than we think, actually, because this
Yeah.
comes quite often. In
Yeah.
young women, this is much more common than we think.
Okay, we move on to the next case. Vishuddha, otherwise we'll never finish.
Yeah, we'll go to
So, case 2, she's a primary gravida with IVF pregnancy. At the present moment, she's 19 weeks, sudden onset of unilateral pain with vomiting on the left side. And you've done an ultrasound. The left ovary is showing not evidence of torsion, but it's enlarged, about 6 by 7 centimeters. A question goes to Gauri.
Yeah, so at the
What is your
outset,
diagnosis?
yeah, at the outset, it looks like a ovarian cyst accident from the history. It just needs a more detailed history, but the main points have been highlighted already. I would confirm it by supportive examination of the abdomen. In terms of ovarian cyst accident, most probably it might be torsion, but sometimes it could be hemorrhage as well. And in such cases, normally we sort of assess the patient clinically to see whether she needs to go to theater immediately or whether some pain relief helps to settle her symptoms or not, especially if it's hemorrhage. Basically, if we are suspecting torsion and it's more clinical plus ultrasound and a Doppler diagnosis to help confirm that, and that's quite routinely done, and it's easily available in most of the units in India and in UK as well. We would then go ahead with surgery. Again, in terms of gestation, she's 19 weeks, so it's an ideal sort of gestation to go ahead with surgery. And it's an acute emergency anyway, so there's no point waiting. I would definitely get the anesthetics, especially somebody with specialist interest in obstetrics, to review the patient prior to surgery for fitness, and go ahead with laparoscopy.
Anyone else wishes to add anything to this case management? Any one of the panelists are welcome.
Actually, what I think is because it's an IVF pregnancy, I think she would have been under constant surveillance because it's an IVF pregnancy, and 19 weeks, I think she is just due for anomaly scan. She would have undergone an NT scan or something before that, and there's a likelihood where we would have seen the cyst before she complains of pain. So in that case, I think we should, if we see the cyst before she complains of torsion or pain, we should counsel the patient at that point of time that such a incident may occur. I mean, the cyst may undergo torsion, and whenever you have severe pain, you should come to the hospital.
Yes, if it has been picked up before.
I think Dr. Anuja has put her hand up. Yes, Dr. Anuja, what do you want to say?
Hi, just want to add, just to add on to what Dr. Gauri said. She mentioned about Dopplers, but in my experience, Dopplers can sometimes show forward flow, and that still does not rule out torsion completely. So I would say if the pain is very, strongly suggestive of torsion, we should go ahead.
So I think in that
clinical
case,
and ultrasound both.
Yes,
Dr. Sushmita, I would just, in partial torsion, sometimes you do see forward flow. So it's a very, it's a catch situation. You don't know whether you must go ahead or you shouldn't. So I think you have to look at the patient in total, stabilize her, counsel her, and I think sometimes the
I think clinical judgment will take over here. Partho wishes to say something. Partho has his hand up.
Yeah, thank you, Didi. Am I audible?
Yes, you are.
Yes.
Okay. So I'm very humble query because in the last all these 2 cases I have seen. So do we assume that we do not put our hand on the tummy of the patient?
Oh, of course.
In the first
That's already been done.
There is no.
We are in dearth of time.
We are discussing about ovarian torsion, and in that guide, because it's a feel of the abdomen, the overall tenderness, the distension. Because
that is the clinical thing. Yes.
That's your clinical judgment. See, in ovarian torsion, what happens is when you do an ultrasound, sometimes it might, some people will, some ultrasonography, it depends on the, depends on the machine, depends on the person who is doing the ultrasound. They might not be able to say it's a torsion, might be able to say torsion, even if it's not a torsion. So these things do happen. So your clinical judgment.
So basically, if it's a large cyst with acute abdominal feature, You have to
Yeah.
suspect something and
Yeah,
go for
Especially
that
if
is the
surgery
the
if
point.
dermoid
clinically
says,
It's a
indicated.
torsion
Many
minded.
USGs don't pick up. Yeah, I mean, many times this happens with us because we are in a medical college. So at night when they do the USG, the juniors are doing. So it is mostly
yeah,
clinical
it
judgment
happens.
that we have to go for. Yeah.
Correct, correct. Okay,
Your
we move on
clinical
to the
must
next
be
case.
very good.
So this is a 20-year-old unmarried young girl coming to your OPD with her mom and says that she has history of right-sided lower abdominal pain and nausea. She looks a bit anxious, but she denies any sexual activity. She's a bit tachycardic, 100, BP is 100/70, but her mother says she's always had low BP like that. So on further query, she says that her periods are usually irregular and her LMP was 6 weeks back. She currently has some brownish vaginal discharge. So we go to Dr. Jayanti. What would be your approach to this case?
Actually, firstly, I would take her history. The history you have already taken, saying that she's a young girl. She's not giving any history of sexual exposure. And now she's having tachycardia as well. So the first thing is after history and clinical examination, I will see where exactly, whether her abdomen is tender or whether where exactly her pain is. And then I will advise an ultrasound. But before that, if I suspect that it could be an ectopic pregnancy or something like that, I would do a UPT also. So then an ultrasound will of course show us the pregnancy, and then we can take it further from that. Sometimes even it may not be an ectopic, it can be an hemorrhagic cyst as well.
Yes.
Or a corpus
Ruptured
luteum.
corpus CLCs.
Yeah, ruptured corpus luteum. So if the UPT is negative, of course UPT is not always conclusive, but we can give her conservative management initially, provided that she is hemodynamically stable, and then we can do her beta SAG also. So beta SAG report will take some time.
So we go to the ectopic way, right?
Yeah.
I
You
think
are suspecting
any
an ectopic.
patient who
Now
comes
here,
with amenorrhea, we have to rule out, even if she's unmarried, because she's come with the mother. She may not give us history, but we have to always
exactly. So
rule out.
here you have to send that
Yes.
mother out of the room.
Yes,
and
yes,
ask,
because
yes.
everyone has faced this problem. Every one of us has faced this.
Every one of us have managed.
Everybody
Yes.
has.
Yeah.
What? Yeah. So this lady, if she's hemodynamically stable, and for argument's sake, say her UPT is negative, and you're suspecting a ruptured cyst, would you admit her or let her go home?
No, I would admit her.
Okay.
I would admit her and keep her under observation.
So Dr. Partho, when you admit her, how will you counsel this patient when you admit her? Because she has got a mom. A mom says, "Oh, she's having a dull ache. Why can't I take her home? Why does she need to stay in the hospital?" And you want to admit her, and you haven't not yet done the pregnancy test. So how will you counsel this patient?
So,
Obviously, like unless we have the beta SCG report in hand, or if the
Partha
UPT.
Bhattacharya. This is for Partha Bhattacharya.
Sorry.
okay, it's okay. Now, there are 2 points you asked. Number one is the pregnancy is not positive because she denies, both of them denies. So I will rather take her in this way, that her vitals are raising, pulse rate are lower BP, and maybe the abdominal findings that there can be. I will not discuss about pregnancy unless it is conclusively proved. What we do in that case, I will say that it can be a rupture of ovarian cyst, or it can be something else that can run serious. So it's better to admit her, support with resuscitation measures and everything, and then to arrange on the investigations depending on the time of the day. Maybe it's a daytime or a night time or a weekend, whatever it be. Doing UPT is very difficult because to deny, we all know this. Then obviously, you have to go on an ultrasound or an serum ECG. But counseling is that my case in this will be towards suspecting an ovarian cyst, some benign things which they won't. I don't think after saying this thing they will not go back home.
So, Dr. Poushali, would you like to anything else? You'd like to do for her?
So once I admit, I have to investigate because right now I've just clinically examined her. So investigation need to complete blood count, therapy, doing a urine pregnancy test or beta ECG as is possible. Urine pregnancy test is
So you do a
always
UPT,
necessary.
you do a beta
And
ECG, anything else?
Ultrasound.
an ultrasound. An ultrasound we'll have to do. A USG of the
Yeah,
lower of
exactly.
the abdomen.
Exactly.
This is a young girl. Now, generally, a TVS or a transvaginal sonography in sexually active patients is always a first line in this case. But sometimes, if the patient does not agree, then even a abdominal ultrasound, a transabdominal ultrasound will help, and that helps to clinch the diagnosis.
Thank you. Thank you. So, Dr. Sandeep, anything else you want to add to this? Dr. Sandeep Biswas?
A beta ECG is very important in this patient
Fantastic.
because
Yes.
sometimes you might have beta ECG leads to many things. If the beta ECG is less than 1000 or 1200, you don't expect to see anything in the ultrasound.
Yes.
Okay, intrauterine or extrauterine. So a
Yeah.
doubling, not a
It has to
doubling
be more than
actually.
1500. So that's a message clear that if you have a beta ECG more than 1500, then only you have got a something you can see.
It's not
in the
1500 in good hands at 11, 1200. You are supposed you can see
Yeah, you can
transabdominally
see,
also.
yes.
Yeah, and a repeat of a beta ECG, if the patient needs to be monitored, then a beta ECG repeat after 48 hours is equally essential. If it is positive at all.
Would you wait for 48 hours?
No, yeah, if the patient is stable and the beta ECG is positive, says that the beta ECG is 80, then obviously I'll wait 40 if the patient is stable or not. Our diagnosis is reaching to either a ruptured ovarian cyst or a ruptured ectopic or a urological cause which we normally forget. It can be a ureteric stone also. Okay. So our ultrasound not only of the lower abdomen but
UPT positive.
Sorry?
Yeah,
No, I'm not if the UPT is negative.
Okay. Okay.
You have to think in all dimensions.
Yeah.
True.
If the UPT is negative, we have to think in the other factors also.
Yeah. So let's go to Dr. Susmita. So what do you think are the causes of pain in the first trimester?
So just one thing, Vishwajyoti, I would like to add over here. We were all thinking about ectopic and what she's not saying, whether she is sexually active or not. But again, we have to make sure that she's not had the emergency contraceptive pills, which very often they have miscarriages.
Yes.
And they come with bleeding, amenorrhea, probably the mom is saying. So we have to make sure that it's not a miscarriage. And then we have to think about ectopic. And while we are doing this, we resuscitate the patient. That is very important. At least give her some fluid while we are waiting for the tests. Because over here, her blood pressure, she's in a pretty low and there's a tachycardia. And we have to make sure that, we are only looking into the pregnancy things. We also have to see the infection things because these are very common in 20-year-old girls nowadays.
So the main causes of pain abdomen, as Dr. Susmita has rightly said, are ectopic pregnancy, miscarriage, corpus luteum cyst structure, which can happen very occasionally. We have found everybody. Ovarian torsion is there and appendicitis is there.
Appendicitis, yes.
Now, this patient, Susmita, can you move the screen, please? So this patient had an laparoscopy done. It was her ultrasound findings showed that she had a 3.5 centimeter to 2.5 centimeter left adnexal cyst, and this was the finding. Okay. Now, can somebody tell me exactly what is happening here? This is not a ruptured ectopic.
No,
is
this is an abortion.
It's a
tubal abortion.
Tubal abortion. It's an impending rupture and an abortion. Tubal abortion.
Tubal abortion. Impending, exactly. Impending rupture
or a tubal abortion. Means like
this is the first thing that
or a
we
tubal
saw.
abortion.
Okay, that there was something on the tube and a lot of blood collection in the POD.
Yeah.
It's an it's not a rupture ectopic.
No,
No.
impending rupture.
Impending rupture or a tubal abortion.
Tubal abortion.
Okay, so that is the reason why she had a dull ache and not a severe pain. Okay, now we move on to case 4. where we have a Sushmita. Can you take this case, please?
Which Sushmita?
Sushmita Chattopadhyay.
Right. The question goes to Sushmita Mitra. She's a 32 weeks pregnant lady. She's presenting with vomiting and severe epigastric pain, mainly in the upper abdomen, radiating to the back. What is your initial assessment of this patient?
If she's having epigastric pain, we and 32 weeks, the first thing we make sure check her blood pressure and her urine protein, and then we look into her, the vitals and whether she's had any gastroenteritis or acidity. These things will come, but if it's radiating to the back, then we have to think about perforation, etc. as well, because
Okay, her BP is slightly on the higher side, borderline 140/100.
Yes.
Pulse is 110. Looks a bit dehydrated. Pulse could be high because of dehydration also. You've done a CTG. CTG is normal. Yes. As Partho said, we put a hand in her tummy and the upper abdomen is very acutely tender. So what would you like to do next?
Then we will simultaneously, apart from thinking about the obstetrics, we'll also have to think about any gallbladder problems, any pancreatitis, or, as we were thinking about the HELP syndrome, when we do her blood pressure and urine protein and do the blood tests for the HELP syndrome and see if she's, had these sort of problems before. History taking is also very important.
Yeah.
Right. So what investigations would you do if we move on to Vidya, Dr. Vidya?
Yeah. So very important is after, examining her, as Dr. Partho said, first see the patient, and then the first examination is with her BP being 140/100. I really want to rule out HELP syndrome at the moment. So I will look for a complete blood count, the liver enzymes, uric acid, and of course a coagulation profile also. So looking at the profile, what we have seen is there is leukocytosis, the CRP is high, but the amylase here is on the upper side. It's 300 and lipase is 250. So it goes more towards, pancreatitis rather than the HELP. They haven't mentioned the platelet count here and a liver enzymes also.
Liver enzymes are normal.
Okay.
Electrolytes are normal. Platelet, I think we haven't mentioned, but let's keep it as normal.
I think so. If we are looking at, pancreatitis, I would definitely want an ultrasound. But at 32 weeks, I don't know how much an ultrasound will be helpful. But also a surgical opinion is very, very important at this point, because as an obstetrician, I have my limitations regarding, pancreatitis. So I would definitely
Dr.
call upon
Vidya,
a
I just liked your, I just loved your statement here. We have our limitations as an
Yes, very much.
We have to involve somebody who knows more than us.
So the ultrasound is showing slight features of pancreatic edema, no gallstone, no evidence of ascites. Baby is also okay. They've done ultrasound together, pregnancy scan normal. So what would be your management, Vidya?
First and foremost, I would like to stabilize her pain, and depending on the pancreatitis, of course, admit her. Definitely.
Where?
Where in a good tertiary center where I have.
Where in the tertiary center? In the ward? In the
intensive care.
Acute pancreatitis. Yeah, HDU, definitely. Because pancreatitis calls for, good support system for her. And then, of course, with the surgical team, and depends now what the surgeon wants, whether he wants to conserve and see how she behaves. Also, at this point, she's 32 weeks. So now I will involve the neonatologist also. In case we need to deliver the baby, then I should be prepared, if required, steroids to be given.
So will you give us steroids with pancreatitis?
I would, as I said, my limitations, I would ask my surgeon and the neonatologist. I think it's a teamwork here. We need to actually,
pancreatitis is not a contraindication.
There is no contraindication
No,
to
there
steroids.
There is no
contraindication. Not a
contraindication. But
contraindication.
I will definitely give steroids because I know that this patient may may go into preterm labor also. So realizing that, I may definitely give her steroids, but of course it has to be in conjunction with the surgeon and the neonatologist, basically.
Like normally with
and I think at this point of time, the gastroenterologist.
The gastroenterologist, definitely.
Normally with acute pancreatitis in pregnancy, we are, we don't deliver. We do conservative management as possible.
In fact, madam, I had a patient who was similar with these typical, and we conserved her. She
Yes.
actually was only 20.
So unless she goes
weeks
into
and we
labor, you
conserved.
normally do no touch technique if there's no gallstone. If it's a gallstone pancreatitis, story is different. But if it is a not gallstone pancreatitis, maybe because of high triglyceride or because of some other issue, then we do conservative management. So even if you deliver, you won't deliver. That I think we agree on that in this situation. So when are you planning to deliver?
I think if she is absolutely fine and she's going well and her follow-up is good, then I think we can take her beyond 37 weeks until.
As well. And how would you monitor the baby while she's in the ICU?
One, though, the ultrasound definitely will give us a good profile of the baby, and we continue to monitor the fetal heart and ask her how she is, with the fetal movements.
I think CTG twice a day or something like that. And you send your junior down to listen to the fetal heart, make the mother listen to the fetal heart. Those things, I think, we all of us do is just reminding ourselves. So basically, we move on to the next case. Vishuddha, you want to take it?
Yeah. So it's a 34-year-old in a second pregnancy with a normal first trimester screening and normal anomaly scan. She had a previous C-section at 39 weeks due to non-progress of labor. She is currently 36 weeks pregnant and presents in ER with severe lower abdominal pain. She is unable to perceive fetal movements. Now I'll tell you, these are all active cases. These are all patients that we have faced in our practice. Her vitals in ER are pulse 90 per minute, mild pallor. Her BP is 140 by 90 millimeter of mercury. This is just about 2 to 3 weeks back. So, Sushmita, how do you proceed to manage this case? Now, this will go to Dr. Vidya again.
No, I think it should go to Dr. Anuja. I think we are coming in a circle.
Okay, let's go to Dr. Anuja.
So we'll first of all call help. This is an emergency, looking at the whole clinical scenario. So
Sorry,
we'll
I
call
can't hear. We can't hear you properly. Just speak
Can
a
you hear
bit
me now?
loud.
No,
Yeah,
she's audible, sir. She's audible.
Yeah, she's audible.
Okay. So I was just saying that this is a clinical emergency. We'll first call for help and call our all the necessary team members like anesthetist. We'll call the neonatologist. We'll let the OT know that we are probably going to have a category 1 cesarean section. She might not be nil by mouth. She might be nil by mouth, but now we will keep her nil by mouth. We'll stabilize her, and unless the clinical scenario clearly suggests some scar accident, dehiscence or rupture, looking at previous cesarean and fetal movements and everything. So then we need to stabilize the mother before we take her to theatre. So we'll arrange appropriate blood products, take 2 wide bore cannulae, send all the bloods, including full blood count, coagulation profile. We'll send all the LFTs, RFTs. Let the blood bank know, because if we have any abruption, we might be needing more blood products. So blood bank needs to know as well. So for example, if I'm in the UK for this, we will activate major obstetric hemorrhage protocol. So everyone automatically knows about it and all the necessary team members will be there. And ideally, we should be delivering, provided the bloods are not suggesting she's in any coagulopathy, we should be delivering this patient within 30 minutes of her getting seen by us.
So could it be an abruption?
Yes, very much possible. Either way, we have to.
Either way, management is same.
Yeah.
Yes, and we are very time sensitive either way. So the management will be same.
It looks more abruption than a rupture.
Yes,
I think our rupture will be able
pressure.
to. Yeah.
And the clinical examination is very important here. That's how we rule out.
Absolutely. Clinical examination is very important.
Absolutely.
Because if you have a skull rupture, the uterus will lose its tonicity. But if you have a If you have an abruption, the uterus will be very chronically contracted.
At the risk of being the devil's advocate, could she be in labor?
Yeah, she can be,
Maybe,
obviously.
Let's
but
not
her
forget
symptoms
that.
are,
Yeah.
yes,
Let's not
first
forget
phase in
that.
labor. Yes.
Yes.
Absolutely.
Sure,
Other
sure.
night only I saw that.
Do
She
the
was
PV
in labor and
examination,
everybody
find
was
her
saying,
dilated.
Partho will
yes,
immediately ask us, have we forgotten to do a V?
Exactly, exactly. That's what.
We should do a PV.
Yes,
Yes, first
absolutely.
thing.
Absolutely. Okay.
I think in
So,
abruption, just feeling the tummy itself will give you the understanding.
correct,
Like
correct.
a hard, stony uterus.
Right.
Absolutely, ma'am.
So immediate management priorities are, we've already discussed. We'll move on to the next case. We just thought we'll give you an obstetrics case in between all the acute, pancreatitis, appendicitis, cholecystitis. We'll just push in one obstetric case that we deal every day. So this is a post-cesarean section, day 4. Patient now has fever, severe abdominal pain and distension. So what it could be, one of these 3. How would you manage? Question goes to Vidisha.
Basically, need to send the investigations, the TCTC, the high vaginal swab, and the urine routine, and all that has to be sent. A USG has to be done. A straight X-ray abdomen also needs to be done, and the other team the surgical team, and has to be called for their opinion also. And depending on the reports, then we take a call. In the meantime, we keep her nil per mouth, give her fluids, and observe the vitals, how she is doing. The urine output is also important here, and the bleeding PV. If there is any foul smell or not, all that we have to see.
Role of CT scan?
Yeah, if the
very
USG
much.
finding is inconclusive, we need to go for the CT scan also in these cases, and accordingly take a call for opening her up or keeping her on a conservative management.
Okay. Can I ask
Can I come
Gauri?
in?
Yes, come in.
Yeah,
Sandeep?
I think clinical examination is utmost important.
Mm.
Presence or absence of bowel sounds or hurried
Yeah,
bowel
that's
sounds.
good.
How much distension? And EVC doesn't have much role to play here. It is
Yeah,
CT scan which will let to know whether it's a CO2 obstruction, anything to the bowel, or even if there is a collection post 4 days post LSCS, that also will be revealed by CT scan. The urgent CT is most important to lead you to a diagnosis.
But again, Sandeep, being the devil's advocate, CT is also not available in small nursing homes.
Yeah.
Yeah, if the
somebody
CT
is
is
done
not
a cesarean,
available,
you go for
EVSG only can show you a collection, nothing more than that regarding the bowels. Then clinically, if you suspect it's to be obstruction or the patient is severely deteriorating, you have to do a exploratory laparoscopy or a laparoscopy.
Now, Sandeep, another thing, if it's a bowel obstruction, CT will not be able to tell you whether it's a bowel obstruction or not.
100% CT will be able to tell you. If you do a
Contrast CT, sir, which is
Our
generally able.
medical colleges,
if
we
you
do a straight X-ray
contrast
abdomen
CT,
first.
a contrast CT will 100% give you a bowel obstruction.
No, no,
about
not always.
What about the
If you do an oral
straight
contrast
X-ray
like
also by
CT,
X-ray followed by CT.
Sir, may I come in here? Sometimes ultrasound is always one of the most initial diagnosis. Ultrasound is one of the initial investigations. When ultrasound is inconclusive, sometimes what happens, it's difficult to diagnose, as Shondipta was saying, an intestinal obstruction, and the patient is deteriorating. Then we go into CT. It's it's good as a second line. But sometimes in urgent basis, if it's not a tertiary care center, you do not have a setup for CT, a straight X-ray abdomen and an ultrasound helps in most of the cases, and your clinical like diagnosis.
Yeah,
like,
the bowel sounds
whether
and
it's
all that.
go in for electrolytes, go in for CBC, CRP, electrolytes. Even if there is a large pelvic connection, it will be able to say, sir, her clinical features, everything will come.
But at this point of time, I think you should be involving somebody, isn't it?
Yes, sir.
Yeah,
The
surgeon.
surgeon has to
Yes,
be
surgeon.
involved.
Absolutely, sir. MDT, sir. Surgical team has to be involved, sir. We have to involve the surgeon at this point of time. Because if it's a bowel injury, we have to open up after C-section. Sometimes it can be a pelvic collection, a pelvic abscess,
Not
a
even
large
pelvic
pelvic abscess.
collection,
yes,
usually.
yes.
I have
Even
seen-
rectal sheath hematoma can also
Present
present
like
like this.
this.
Infected
And
I opened up an abdomen and took out a mop. So
So that is okay. That is
sorry, I went
Sir,
offline.
one thing, sir, if it's a mob and infected, then that is going to be later. Means
yeah,
the
that comes
features
much
will be much
later.
later.
Mostly, sometimes
Now,
the
Vishuddha,
pelvic
there is
abscess
no
is
surgeon
diagnosed.
available. What will you do?
This is a little bit dicey, you know. Sometimes
Yes, sir.
patients will present to you at around 10 days. I think it will be
Yeah.
around 10
15
days
days
later.
postpartum.
10-15 days postpartum. This is day 4
That is,
only.
if it's a
Yeah.
mob, then it will be a little bit later, sir.
Yeah.
Yes.
We have to counsel the patient also about this because you're opening the patient
Absolutely.
for a second
I
time.
think Sushmita
Yeah,
Mitro
that's
is
the
silent
obviously.
for a while. Can Sushmita, would you like to say something about this?
Yes, I would 100% agree that mobs usually don't come up on day 4. But yes, counseling is very important because she's just had a baby now. She's unwell, and but the good thing is that we can do CT scan and we can come to more or less a conclusion as to what is going on, whether it is
Would you
bowel
do a
or
CT with a contrast, or would you do a CT without a contrast?
now we can do it with a contrast.
CT, sir. Right. Yeah.
Right. Okay. Sorry, I went offline a little bit. So we just, nearing the end of our panel. We just like to remind the audience that we need immediate senior review of those, not the panelists, but those who are listening. Maybe some juniors are listening. That if the patient is hemodynamically unstable, please ask for help. Signs of peritonitis, severe vaginal bleeding, absent fetal heart rate, fetal distress, suspected rupture, placental abruption, sepsis. We all manage this in our day-to-day cases. But if you are working in a hospital, please take a second opinion. And these are the cases that lands up in a lot of trouble. And you please ask for a senior review and manage together. So basically, to reiterate the key points in this panel, maternal stabilization is the priority in all cases. Surgery, however, should not be delayed because she's pregnant. Like in case of acute appendicitis, etc., when the situation demands. Obstetric cause and non-obstetric cause sometimes may be there together. So they may coexist and we might have to manage them together. So early multidisciplinary team involvement will always improve outcome. And ultrasound still remains the fine line, first imaging modality followed by MRI. And when MRI is not available, maybe CT scan. Laparoscopy is safe, as we have discussed in this evening, in all trimester, but it needs to be by an experienced surgeon. If it's not an experienced surgeon available, please open up and go for laparotomy. Yeah. Left lateral tilt is important. Do not forget after 20 weeks of pregnancy. Do not forget to give after a big laparotomy or a surgery. Do not forget to give thromboprophylaxis, which we do. And obviously, if the baby is viable, CTG or ultrasound as may be required before and after surgery. So we go on to have
one thing before Sushmita,
wisdom.
One thing before we finish up. If about VT prophylaxis, sometimes, if the patient has got a coagulation abnormality or something, we are a little hesitant about giving LMWH. What else can you give? Not
give her TED stockings.
No, not TED stockings.
Clotron.
Huh?
Clotron.
What we can do is
hydration and early mobilization.
Yeah, but if she's had a laparotomy, mobility might be a bit difficult in this
IPCD, Sushmita, the intermittent pneumatic as you said,
yes,
which is always available in the wards.
It's available in
IPCD.
It's available in every corporate.
Even in the wards, everywhere it's available.
Yes,
you can straight away give her IPCD.
Okay. So if we can come to our first panelist again, one pearl of wisdom regarding this situation in which we all have faced and are going to face in our practice. Start with Anuja. Please, Anuja.
I would say informed consent, because most of the obstetric emergencies we are getting guided by our clinical judgment rather than the confirmed investigation or reports. So informed consent, explaining pros and cons and positive and negative findings is very important. That's my take home.
Thank you. Vidisha?
Yeah, the most important thing is clinical examination. So after sending all investigations and doing all like CT scan and MRI is okay, but the history and clinical examination is the most important part, and we should always highlight and focus on that.
Next, I think Partho hasn't spoken at all. Partho?
Yeah, we have come far away from our ages only to obstetrics and focused. But we should not forget about the basics of all the about pancreatitis, about the basics of the cholecystitis, basic of appendicitis, and all these things. So we just should just keep in our mind the basic things that we should not out of our mind. That's what I say. Keep the basic
Absolutely.
ideas of all the
Absolutely.
possible diagnosis.
Absolutely. Yes. Yes, anybody else want to add anything?
Yeah, I want to add
I
one
want
thing. Like whenever the patient is having acute abdomen, suppose she's hemodynamically not so stable. So we have to, I'm again regarding to counseling, for us, for a doctor, it will be very challenging to take a decision. So we have to inform the patient about the risk versus benefits. Because the patient will say that this surgery had risk, why did you do it? Or something like that to avoid medical legal complications later. So we have to counsel risk versus benefits and what are the probable, what will be the complications, like that also we have to explain. Like patients usually ask कि बच्चा भी बचेगा क्या, माँ ठीक होएगी क्या, दोनों बच्चा हो. So we have to give them the real picture so that we don't get into trouble later on.
Yes, and
Yeah, the
in
documentation.
documentation, exactly.
Yes.
Yes.
Documentation is the most important part. If you haven't documented, you haven't done it. Okay?
Correct.
Yeah.
Yes.
And
Yes,
also post debriefing.
multidisciplinary team, when we are doing it, we should always be there because, after all, the patient knows me for the obstetrician for the longest time. So whenever we are deciding something, it is very important, let the surgeon do it, let the medics do it. You should be very much proactive in the multidisciplinary team.
So, Dr. Pusali, one
Yes, sir.
take-home message from you?
Correct. Clinical suspicion, timely intervention based on your clinical diagnosis with investigations. Call for help as early as possible. Go for an MDT review. That is very important. Don't wait. And another thing that I would like to say is we nowadays, to avoid medical legal problems, you do an MDT review where you call the patient's relatives, document it. We have video meetings or we have, those consent forms which we do for that is very important. Whatever you're telling, if you need a surgeon, if you need to open up second time like acute pancreatitis, sir, I had one such case. So there, you have to document, as they said, go for an MDT documentation to be on the safe side if something
We have
happens to
to
the
do
patient. That's
an
very
MDT
important.
documentation,
Yeah.
as you said, and it has to be under video surveillance so that.
Yeah, in our hospital, we do it under video
Same
consultation.
here.
We do it. But sometimes I'll tell you, when you are doing an OT or when you are operating and you find out something very sinister and you come and tell the patient, sometimes the OT doesn't have that audio thing.
No,
So
that's
that is
not needed. The
something
images. I mean, you take the snapshots in the OT and you can preserve it in your bedhead ticket.
Yes,
That's because
It's a very
which they
important-
do.
It's a very important thing. Absolutely. So what about Dr. Sandeep? What would you give us a one golden
You should be safe towards your patient and safe towards yourself.
Fantastic. Thank you. And Dr. Suspita, Suspita Mitro, what would be your golden message for us?
Yes, see the patient like clinical examination, investigation, and prompt action. So these are the three things we have to just add. Every step we have to keep the patient and the family in the loop.
fantastic. You have to keep them in the loop. You have to keep them informed. You have to talk to them as if they are one of their family members. This is one thing that you have to learn, that we have learned over the years, that you have to be one of them, like if you are treating your family member. Anyway, so Dr. Vidya, anything else you want to add? Dr. Vidya?
I think Dr. Vidya
I
might have
checked
left. She had an emergency.
Okay. That's
So
fine. So I think we have come to the end of our discussion. Susmita, are we okay?
Yes, we have. I think I went offline. I'm having a bit of trouble with my net today.
Okay.
But yes, we have. Thank you very much, all our panelists.
Thank
I am
you.
really grateful to all the panelists for making this session so wonderful. It's been a fantastic session, and I must say that all of you gave us the exact points exactly as we wanted it. I mean, it's a pleasure. I was sharing this slide with Susmita just about 1 or 2 days back, and then she corrected it. Obviously, I am not that good in making presentation, and then it has come out as a very fantastic presentation. Thank you very much. Thank you.
Thank you, everyone. Thank you.
Thank you, Shishmati.
Thank you.
Thank you, Vishwati.
Thanks, everyone. Good.
Thank
Thank
you,
you so
West
much.
Zone. Thank you, Dr. Baser.
Yes.
Especially, I loved working with Anjum. We
Yeah,
got on
same
well.
here. Thank
We'll
you.
organize more such things later.
Thank you. We
And
really
thank
got
you, Dr. Archana Baser, if she's there. Thank you for organizing this. Thank you
we
very much.
really started the panel late, but it was worth the wait. The scenarios, the panel discussion, it was very interesting on serious issues, but having its own light movement. So we all really enjoyed it. Thank you, ma'am and sir.
Dr. Anjum, I'll tell you one thing. If
Thanks,
you have
everybody.
Susmita
Thank you.
and myself as a moderator, it will always be interesting.
Wow. Somebody is confident and we are offline. Somebody is confident.
Okay. Thank you very much.
Thank you, ladies and
Thank you.
gentlemen. Good
Yeah, all
night.
of you.
Enjoy
All of
the
you.
semi-final. We are not going to
Yes.
sleep.
And take it easy. Thank you.
Yeah. Don't forget to enjoy the semi-final today.
Yes.
Thank you,
Yes,
each
of
and
course.
Thank you, each and every one of you. It was
Thank you very much,
fantastic.
Thanks,
Rupali.
everyone.
Thank you,
very much.
Rupali.
Thank
Bye.
you.
Bye.
Okay, bye 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 bye.
Bye.
Thank you. Bye. Good night.
Good
Good
night.
night.
Good night, Pragya. Thank you for
Good
joining.
night.
So much for the chance, for the opportunity.
Thank
Thanks.
you, Rajivda.
Thank you.
Bye. Bye.
And Vidisha, your dance was very good. I think you were the best.
Oh, is it, ma'am? Thank you so much.
Seriously.
Today, your talk was wonderful, ma'am. Loved your talk. I've taken the snapshots of the slides also.
Sometimes, last minute things work out better, I'm smiling because since last evening, my
Yeah.
mother, now she's tucked up in bed.
Okay.
And tell Poshali she's logged off, but for cooperating the other day because she was
Yeah.
going to Saharsa for that CME.
Okay.
But then,
Yeah.
but,
Okay.
she had 102 fever and then lots of
Hmm.
IV antibiotics, nebulizers.
Right.
But she's striving her best to be there for stillbirth con.
Right. Yeah.
You're
Oh,
not
yeah.
coming
Hopefully
down?
she'll be better. Yeah.
You're coming down for stillbirth con?
No, ma'am. I'm going to Faridabad for that one
Coma is
environment
coming.
one. Environment is in 25th and 6th. Stillbirth, I'm not attending, ma'am.
Okay.
Yeah.
I was one of the contributors for is it that nutrition and something?
Yes, ma'am. Yeah. Okay. Thank you so much, ma'am.
Thank you. Bye.
Thank you, Pragya, ma'am. Thank you,
Bye.
Dr. Vidisha.
Bye,
Thank you,
Dr.
Dr. Rajiv.
Thank you.
Thank
Bye.
you, each and every one of you.
Yeah. Thanks.
Thank you, Rupali. Thank you, Dr. Ruchi. And
Thank you.
thank you, Sudeep sir, for organizing everything. Pragya ma'am, thank you for a wonderful talk. And all the panelists and moderators. Thank you so much. Good night.
Good night.
Great efforts, Anju. I think I was connected with you in ISOPUB, correct?
No, I think we were connected in that menopause webinar, if you remember, ma'am.
Yeah.
That
That's
was
there.
right. Yes, yes.
Yeah, that's there. But
Yes.
I thought you had something to do with the, I mean, ISOPAP, one of the
No, ma'am.
chapters.
No.
Okay. Then it must be some other Anjum then.
Yeah, ma'am. See you, ma'am. Bye.
Okay.
Thank you all. Thank you.
Bye.
Good.
Bye.